Yes, it's a good question. First of all, I think it's good for the patients because we don't need to take care of the patient to stay in the hospital if there is no reason. For example, we know that nosocomial complications are possible. And in particular for elderly patients, I think it's no good to stay for a long time in a hospital. There is a risk of loss of autonomy, confusional problem and so on. And I think for the patients, when there is no reason to keep it in the hospital, in fact, when there is no complication and he could go back to his go back home without any problem, I think it is a good option for the patient. Second, it is a good option for the hospital because you know that there is an increased number of patients to treat by TAVI with the recent guidelines of the European Society of Cardiology. And the hospital is still the same. We still have the same number of beds. So, you know, the resources are constrained. Particularly, we have seen that during the COVID area. So we need to optimize care for patients, and in particular to optimize the procedures and the peri-procedure to reduce length of stay for all of these reasons. In fact, we published around 8 years ago that it was possible to reduce length of stay without any safety problem. But you know, in France, length of stay was still very high and very long, and we wanted to implement the same thing that we have done in my department in the Rouen University Hospital to other departments. And it was not so easy because, you know, when you want to change something, it's sometimes very difficult. And people were aware about safety, in particular for conductive disorder, for delayed conductive disorders. So we have to educate them and to try to do the same as we did many years ago, in fact, in Rouen. We started by a dedicated webinar because we were in the COVID period. We couldn't go to each of the center. And before we decided to include 20 centers, 20 French centers who accepted to participate. And first of all, we randomized the 10 centers. 10 centers in the control group and 10 centers in the intervention group. And we only, of course, do the formation in the intervention group. We started just by a webinar for 2 hours to explain what are the reasons of failure of early discharge and what we recommended to reduce. There was 20 quality of care measures to reduce length of stay, how to implement them. And in fact, it is very different among the centers. And generally, among the 10 measures, some of them were already in place, in fact. So we explain that, and so they say, okay, we are going to try to implement them in our departments. And then we do what we call an action plan in each center, just by phone call or webinar also, but face-to-face, this fact, center by center, to evaluate how it was possible to implement as much as they could do during the study. They had 2 months for that. And later on, we started the enrollment of the study, and we repeat what we call a self-assessment. They have to say for each measure what is the percentage that they can do for the patients. And interestingly, it's moved progressively, and it was quickly very, very high because at the end of the study, nearly 90% of the centers implement all the measures. I believe it is not so complicated to do that because if you see all one by one measures, they are easy to adopt, but they are not easy to adopt in all your departments. You need to convince everyone. You need a chief who is very convinced also that we have to reduce length of stay. And it is, I will say, a work which is repeated every month to maintain the pressure, I will say, to try to reduce length of stay without compromising safety of patients. That is very important. And it is another point. We clearly showed that 30-day mortality or 30-day readmission were similar in control patients or in the intervention group. That is very important because some of my detractors said, oh, be careful for the safety, and there is no problem with safety. I think it is very important.